We're going to continue on with our liver disease content. Liver disease content is in your textbook module 12 under metabolism. Starts on page 885. We got through a lot of our information for our introduction. This is part 2. We've already covered our liver functions. We've already covered our pathophysiology, our risk factors, cause of liver disease, ways to prevent, and for clinical manifestations. As we continue through our content, collaborative approach, I believe I may have skipped this slide, so I want to talk about it. So collaborative approach to a patient who has liver disease needs to be holistic, meaning that we're addressing the physiologic, the psychosocial piece, and spiritual. Collaborative will also be counseling, job coaching, behavioral therapists. We'll bring in that nutritionist to help us with our weight loss that we see in our patients, in our cachexia or severe undernutrition or malnutrition. So if I'm wondering about nutrition, remember, go back to your nutrition content you had already, which was part of our metabolism content, our starvation, right? And then alcohol and drug treatment programs. Another one you can add to this list is going to be when your patient is decompensated. What are they going to do? That patient has portal hypertension, is starting to have all these signs and symptoms, right? So now we've got who else involved? We've got pharmacy involved. So add pharmacy onto this slide. As we go on slide 8, I did skip this slide. I do apologize for that. I wanted to make sure I came back to this. So lab and diagnostic tests. Lab and diagnostic tests for our patients with liver disease. We'll do liver function studies, so we'll look at the AST and the ALT. We'll look at the AST and the ALT for our patients. And whenever we are looking at these normals, our values, our patient's ALT level will increase if they have a liver disorder. And so we need to make sure that we are assessing our ALT. The AST is present in patients that have high metabolic activity, so it can be seen in liver disease. So ALT is going to be telling us your patient has something going on with our liver. Our AST is going to be telling us there's high metabolic activity. So it can be with different tissues. It can affect the heart, liver, skeletal muscles, or the kidneys. However, when we see the AST that is elevated and we see the ALT elevated with it, we are thinking liver disease. ALT is always going to be to liver. AST is going to be elevated whenever there's damage to a couple of the organs. AST will be elevated in a patient who has a liver problem. So looking at the AST, normal values is 10 to 40. AST, normal values is 10 to 40. The ALT is 8 to 40. ALT is 8 to 40. So if I don't want to have to remember the different numbers, so if you see the AST or the ALT that is greater than 40, that means it's increased, and that would tell me that this patient has something going on with their liver. As we look down, we're going to look at the complete blood count. That's their CBC. It is going to tell us about what our patient's hemoglobin, our patient's, our CBC is going to be our chemistry panel, which is going to tell us about our patient's electrolytes. So we'll be wanting to look at that sodium. We'll be looking to see what their phosphorus is. We'll look at their magnesium. And a lot of these patients are going to have nutritional deficits. So we'll see a lot of electrolyte imbalances. We'll also see, as we're looking at different things and we're looking at the coagulation and we're looking at all this stuff, we are going to notice that our patient is going to be anemic. Our patient's going to be anemic, and our patient is also going to be thrombocytopenic. So our patient is going to have a low platelet count. Our patient is going to have a low hemoglobin, hematocrit. Our patient's going to have low red blood cells as well. You should remember all of those values and be familiar with those terms. We talked about our electrolytes, but we are also, whenever we are looking at our labs for a patient who has a liver disorder, we also need to look at their bilirubin to see what their bilirubin level is. When we're looking at a bilirubin, normal is 0.3 to 1. So if I see a bilirubin that's greater than 1, I am concerned. When that bilirubin gets over 2, jaundice will occur. So normal is going to be less than 1 on the bilirubin. And whenever I see it higher than 1, it tells me something's going on with the liver. It could be that maybe it's something that's going on with the gallbladder as well because it has to do with the bilirubin, right? But I can see that bilirubin being elevated in a patient who is at 2, that patient is going to be jaundiced. We'll also look at the albumin. The albumin for this patient, because that's going to tell us about protein. Normal is 4 to 6, so anything less than 4, my patient has a nutrition problem. We'll look at the ammonia levels. Normal is 15 to 45. So if it's higher than 45, if my ammonia level is higher than 45, then that means my patient is retaining that ammonia. That toxin is building up in their body, in their brain, and that patient is the higher risk for hepatic encephalopathy. And I'm going to see some LOC changes, and that patient is going to have some altered mental status. So ammonia greater than 45. Then I would be concerned that that patient has hepatic encephalopathy, and I would definitely want to make sure that I am giving that lactulose to that patient to pull that ammonia out of the body in the form of stool. Glucose, we talked about looking at glucose because our patients can have glucose alterations. They can have too high or too low. If our patient has too high of a blood glucose, then what would we do? We would give them, we would talk to the doctor, make a recommendation for the physician about insulin. And so that would be a short acting insulin for that patient. And so when we give that insulin, what's the side effect of giving insulin? We can go to a hypoglycemia. So our patients with liver, they can either have normal blood sugars, they can have high blood sugars, or they can have low blood sugars. If they have a high blood sugar, over 200, I'm going to be making a recommendation to the physician about, do we need to be checking this patient's blood sugars and maybe starting a sliding scale of a fast-acting insulin. We'll also look at their cholesterol levels, their HDL and their ADL. When we're looking at their HDL and we're looking at their LDL, so if we see our patient who has has their cholesterol levels are elevated, then we would think about our patient, we would think about our patient not being able to digest their fats, right? And so greater than 70 for a male or greater than 85 for a female is what we're looking at. That would be a total, our patient who has, whenever we're looking at the HDL and the LDL combined, if I see somebody who has a 200 HDL, I would be concerned, right? Okay, moving on. Also, when we look at our diagnostic test, abdominal ultrasound, why would they do an abdominal ultrasound? Where would they even look? Well, remember, where's the liver? Right upper quadrant. So that's where they're going to do the ultrasound. They're going to look at the structures, right? They might do a CT, an MRI. They might do an esophoscopy or endoscopy where they put the tube down the throat, right? And are going to try to look at the liver. They might also do a liver biopsy to see if the liver is diseased or not. So there's a lot of different things that they can do for lab and diagnostic. We already talked about pharmacology therapies and we talked a little bit about our medications. So let's just remember if we're going and we're giving a diuretic for a patient and we're giving spironolactone, that's the potassium sparing one. So our we're not necessarily checking, we're checking to see what our potassium level is. As long as our potassium level isn't too high, we can give it. But what do we need to check before we give any diuretic? Blood pressure, heart rate. What do we need to check after we give the diuretic? We need to check their blood pressure, heart rate, and their urine output. If we're giving a diuretic furosemide, that one wastes potassium. It lets go of potassium. Our potassium needs to be at least what? Normal potassium is 3 to 3.5 to 5. So if our potassium level is 2.3 and I have an order for furosemide, I would be contacting my physician and making a recommendation, right? All right. Another medication that we talked about is lactulose. So with lactulose, we're going to be documenting the number of stools that our patient is having that day, and we want the COCA of the stool documented. With our beta blockers, whenever we give beta blockers, what do we need to remember? We remember to count the heart rate, should be greater than 60, and we're also going to check the patient's blood pressure. Our patients, sometimes their blood pressure can be low because in their vessels they might be dry. So it's really important to make sure that you are checking your patient's blood pressure before you give that beta blocker. That patient might have a blood pressure of 103 for a systolic. That's okay to give that. Just make sure that your heart rate is greater than 60. Ferrous sulfate, after you give a beta blocker, what do you check? You check the blood pressure and the heart rate again, of course. And then our ferrous sulfate, our folic acid, folate, B12, B complex, those, and we're looking at those things. We're looking at iron, right? So we're thinking about fatigue for our patient as a follow-up, right? That's what we want to ask about. And then we are also hopefully effective with our medications, and the patient feels like they have a little bit more energy, maybe not so tired. Also with those vitamins, the A, D, E, and K. So we're thinking about with that K specifically, what are we going to assess afterwards? We're going to be thinking about the vitamin K and what does vitamin K do? So we do not want our patient to be bleeding, right? So why are we giving that vitamin K? Make sure you remember what vitamin K is about. Remember, it is vitamin K. All right, we talked about our toxins. We went through and our management and treatment for our nutritional therapies and talked about those and surgical procedures. We talked about lifespan considerations is one that I think that I actually skipped, so let's go back through it. I apologize, y'all. Lifespan considerations, we talked about liver disease being one of the top leading causes of death according to the CDC. Whenever we look at a condition called biliary atresia, this is where the bile ducts fail to develop and are closed, leading to death by age 2 if not treated. The cause is unknown. Generally, the newborn is asymptomatic until 2 or 3 weeks, and then they start having jaundice in the abdominal distension, and then hepatomegaly becomes apparent. Then with our patients, what do we see? It affects the infant, the toddler, and child and adolescent. But with this specific biliary atresia, this child will die if this is not corrected. So very prompt, very prompt. As the kiddo gets older and we're in the infant stages and in the toddler stages, they have easy bruising. And so it might take them longer whenever they get a little boo-boo or cut. They'll have that prolonged bleeding time, so it'll take a little bit longer. They might have that itching, and with all of our patients, with their age, white clay-colored stools, tea-colored urine, and the elevated LFTs. LFT stands for liver function test. Treatment for this biliary atresia, we need to get it by taken care of by before the age of 2. If not, they will die. So treatment is surgical intervention to relieve the obstruction and supportive care. Sometimes they do liver transplant. If they do liver transplant, then the patient has to take anti-rejection medications for the rest of life. Cirrhosis can occur at any age, presents like liver failure, continues to worsen over time. Treatment is symptom management and liver transplant. Nursing process, we did go over, and we went over all of these things, and now we are on slide 18. 18 is where we're going to start back. I do apologize for those couple of slides that I did omit. I wanted to make sure I went through and gave you the information that you need. So let's talk about jaundice. Remember, we talked about the patient having malaise. We talked about the compensated, which means that the patient is able to compensate for the signs of liver failure that they're having. They have the fatigue. So what are we going to do to manage the fatigue? We will do frequent rest periods, right? We don't want to over exert our patient. What are we going to do for the loss of appetite? Well, we're going to provide them foods that's within their dietary restrictions that they like, right? We're going to make the food appeasing. Once they get to the uncompensated, that's whenever we're going to see all these other signs and symptoms that start appearing. The edema, the ascites, then we're going to see the esophageal varices, all these different things. So are we still going to have the fatigue, malaise, and the weight loss? Yes, we're going to have all those things. So we're going to be making sure that we are clustering our care, but making sure we don't wear out our patient, making sure we're providing rest periods. We're also going to be giving few foods of choice that is within their dietary restriction. We're going to also assist them with ambulation, but we're going to add some more things because now they have a sign and symptom that we need to address. We need to address their jaundice. So what is jaundice? It's the yellow discoloration, and it's because we talked about the bilirubin exceeding 2. And it can be because of hepatocellular jaundice or an obstructive jaundice. So hepatocellular jaundice meaning that the liver is affected and that's why we're having it. Or it could be obstructive jaundice because we have an obstruction, maybe like that gallstone. So there's different reasons for jaundice. We're focusing on liver, but the patient has a liver problem, but it can cause jaundice. So staining of the eyes, the skin, and the mucous membranes. They'll have that, that also gives that color of the orange or the amber colored for that. Urine, and then the stool. What about the stool? The stool is that light colored, that white or clay. It doesn't have that brown color. This patient who has jaundice has extreme itching. So what are you going to do, nurse? You are going to help relieve the itching. How can you help relieve the itching? Your patient says, I itch, I itch, I itch all over. What are you going to do to help them? So think about basic care and comfort. We can give them a warm washcloth, and that can help to soothe as well with those itchings. We're going to educate them not to use any perfumes or any soaps that have perfumes or any lotions that have perfumes. If we can give them they might even want to take a warm shower. We don't want it hot, or we do not want it cold. We want it to be tepid, which is a warm. We have problems with vasoconstriction and vasodilation, and that can complicate things. So we want it to be a tepid. We want them to take a tepid bath, tepid shower, or use a warm washcloth. But some of those things that we can do is teach them to use non-fragrance. So fragrance-free soaps, fragrance-free lotions are okay, but we don't want any perfumes. We are going to tell them, do not scratch. Well, it itches. I know we have to do other things. Why don't we want them to scratch? Because if they scratch, they can scratch so hard that they actually break open the skin and then they can bleed from that site as well. So we need to make sure we keep those nails trimmed, and we want to educate them to refrain from itching. If you're doing all those different things and the patient is still having itching, and you're doing all the independent nursing interventions, things I can do without an order, talk to your patient and about talking to the physician to see if there's anything else that they can do for that patient. At times, I have seen them give Benadryl to the patient for the itching because it was so severe. But you have to remember that where are medications metabolized? Medications are metabolized in the liver. So you want to try to avoid any additional medications for the patient that the liver has to process. Dyspepsia, which means heartburn, and intolerance to fatty foods. We'll see that with our patients too that have jaundice. Why? And it has to go back to what bilirubin does. So, what are interventions? Once again, refrain from scratching, keep the nails short, a warm, tepid washcloth, shower, or bath, non alcohol based soaps, non perfume based soaps, and lotions. That is what you're going to do, nurse. Portal hypertension, you can see on this patient with portal hypertension. And portal hypertension is in your textbook on page 890. Page 890 in your textbook is where I'm at now. Like I said, I'm going to be jumping around a little bit. I wanted to start with portal hypertension because portal hypertension is one of the reasons why we see some of the other conditions. So with portal hypertension, we see esophageal varices. So remember I talked about the veins in the esophagus. They can get very torturous, kind of thinking about like our varicose veins in our legs, right? So we have those esophageal varices, we have that collateral circulation, we have those esophageal tortuous vessels in our esophagus, and what can happen is they can break open and bleed. We also see with our patients, we see caput medusa. Whenever we're looking at our image, caput medusa is those blue spider-like veins that are on the abdomen, and that is due to the collateral circulation. The blood vessels are trying to find a new route. Our patient also has marked ascites, as you'll notice, and it's all because that portal hypertension, that portal vein has so much pressure on it. We'll see with our patients as well. They can have anemia, they can be neutropenic and thrombocytopenic as well. Liver failure is often a sign the patient is not doing too good. Whenever we see these things, we see the portal hypertension. And so we think about what medications we're going to use. We talked about using a beta blocker. We talked about using a diuretic on these patients. So whenever I look at this image, it makes me think about the reasons why we're using what we are. And I look at the image of the anatomy, the smaller image of the liver, and it shows me the portal vessel. And so when I'm looking at that portal vessel, that portal vein, it makes sense. So portal hypertension is silent. So people don't know that they have portal hypertension. It just kind of sneaks up on them. Now it's not, whenever we think about portal hypertension, just because it has the word hypertension in it doesn't mean that I have hypertension through all the vessels in my body. That is not what it means. Portal hypertension has a word in front of it. It's not regular hypertension. It is portal. So it's at that portal vessel. So it's at that portal vein. That's where the hypertension is. It is silent. And so what medications do we give to treat it? We give beta blockers, our OLOLs, like our propranolol, or we can give our propranolol is one of our medications that we give for portal hypertension. Another medication that we could give for our portal hypertension is our nadolol is the other name for it. And so complications of portal hypertension includes our ascites, our varices, and our hemorrhoids. If we look on page 888, it talks about with portal hypertension, there's pressure that builds up within the portal venous system. It shunts blood through the lower pressure collateral veins. That's that caput medusa, right? Varices end up developing in the esophagus, the stomach, and the rectum. Remember, those can break and bleed. Ascites occurs as increase in hydrostatic pressure in the portal circulation forces fluid out of the capillaries and into the abdominal cavity. Portal hypertension also leads to hepatic encephalopathy and spontaneous bacterial peritonitis. So if we have all that fluid in the abdomen, can we get a peritonitis? Yes, we can. We can get bacteria in the abdominal cavity. And that bacterial peritonitis is a medical emergency that we'll talk about. So that kind of gives you an idea about portal hypertension. So let's talk about splenomegaly. So thinking about splenomegaly, portal hypertension shunts blood to the spleen through the splenic vein, and it causes splenomegaly. As a result of that, the red blood cells, white blood cells, and platelets are removed from circulation at an increased rate. Therefore, when we go and we look at our labs, our white blood cell count, our platelets, and our red blood cells, all those things are going to be decreased. So we will have a patient who is anemic, and we will have a patient who has leukopenia. We'll have a thrombocytopenic patient. So we need to make sure we are trending our labs. We are watching for fatigue because of that anemia. Telling our patient to report dizziness. We're telling them to rise in stages because of that anemia. We're watching for infection on this patient because of the leukopenia, and we're watching for bleeding on this patient because of the thrombocytopenia. So let's look about a complication of portal hypertension. Another complication that we have is the ascites that we've been talking about. So ascites, as the portal hypertension increases, it forces the fluid out of the vasculature and into the abdominal cavity. We have vasodilation that happens, and it's going to end up reducing our blood volume, triggering our RAS, and releasing of ADH, the antidiuretic hormone. If we release antidiuretic hormone, then what happens? It reduces the absorption of water and sodium. So it reduces the reabsorption of water and sodium, and it contributes to the ascites and the general edema that we see in our patients. We have a decreased serum albumin, and that further exacerbates our ascites, reducing the serum ontonic pressure or the osmotic pressure, right? And it allows fluid to leak into those extravascular compartments. So it is a collection of fluid in the peritoneal cavity. And what causes it? Portal hypertension causes it. And so serum proteins in the renal response occurs, and now we have a belly that is full of fluid. And I'm looking at this patient. Do you think this patient is comfortable lying flat? Absolutely not. This patient can't breathe laying flat. So how do we want to position this patient? Do we want them all the way in high Fowler's position? No, they're not going to be able to breathe. So the best position for these patients is semi-Fowler's. A patient with ascites, they do not need to be flat. They do not need to be at 90 degrees. They need to be at 30 to 45 degrees, that semi-Fowler's position. That's going to help them with breathing. Think about a pregnant belly, somebody who's pregnant. Whenever their belly gets really big, they can't sit straight up because it hurts to breathe because that is pressing up on their diaphragm. They can't lay completely flat because all the weight is right there on their abdomen. They can't breathe. So this is like the ascites patient. It's fluid that's in that peritoneal cavity, and this patient cannot breathe laying flat. This patient cannot breathe if they're sitting 90 degrees. So semi-Fowler's is the best position for this patient. So, ascites, nursing management, what are we going to do? We're going to monitor our INO. We're going to monitor that abdominal growth. So, we are going to take a tape measure. Yes, your units have tape measures. You, nurse, are going to get a tape measure and you are going to monitor the abdominal girth at the beginning of your shift. You're going to monitor the abdominal girth at the end of your shift. And you are going to trend it to what that abdominal girth has been over the past few days. Is the patient getting better? Is the patient getting worse? Also, you're going to do your daily weights on your patient. That will tell you about your patient if they're retaining those fluids, right? Monitor their respiratory status because remember, we can compress that thoracic cavity, which inhibits that lung expansion. We're going to monitor our labs, our serum ammonia, our creatinine, our electrolytes, all of our liver labs we're going to look at. We are looking at the AST, we're looking at the ALT, we are looking at all those labs, but specifically for ascites, we are going to, because of that portal hypertension, we are going to be looking at that ammonia level to make sure that our patient isn't getting all those toxins and getting hepatic encephalopathy. But we're going to be really, really focused in with ascites on what that sodium and potassium is doing because of the inverse relationship. We're going to be looking at that creatinine. Those are going to be the big ones that we are looking at for ascites. We're going to look at all the other ones because it's a liver patient, but specifically, we need to know what that sodium and potassium is doing. We need to know what that creatinine is doing as well. So I talked a little bit about a paracentesis. So here's information for a paracentesis. So paracentesis is a treatment for a patient who has ascites. And so what are you going to do, a nurse, as you're helping the physician, assisting for the paracentesis? We need to make sure that we have a signed consent and we identify the patient with two identifiers. We are going to assess their coagulation panel because the doctor is putting a needle into their abdomen. And we already know that they have thrombocytopenia. We are going to offer reassurance and education to help alleviate anxiety for the patient. We want to make sure the patient voids prior to having a paracentesis. Why? If they have a full bladder, we do not want the bladder to accidentally get poked whenever they are doing the paracentesis. So the patient needs to do what prior to a paracentesis? The patient needs to void. For the paracentesis, we're going to place the patient in an upright position on the end of the bed or in a chair. Their feet need to be supported on the floor. If we don't have, they're not on the floor, then we'll get a stool to make sure that they are supported. We will put a blood pressure cuff onto the patient's arm and we are going to monitor the patient's vital signs during the procedure. Once they pull off fluid, and I'm talking they pull off 1 or 2 or 3, 4, maybe even 5 liters of fluid at a time. So, man, that can cause a lot of volume to be coming off that patient. That can cause a lot of those different disequilibrium things that can go on and all those fluid problems. And so, with those vacutainers that they actually collect that fluid in, we can send a sample of that. We send that to the lab for culture and sensitivity and other tests that the doctor writes for. We want to administer salt pore albumin or another colloid to prevent that post-paracentesis circulatory dysfunction and help keep that patient hemodynamically stable. So it is a salt pore albumin that we are generally administering after a paracentesis, and that is to help with that circulatory system to make sure we have that volume. We took volume off. We need to replace volume for that patient. Complications of ascites. So a complication of ascites, remember I talked about, was fluid is in the peritoneal space. So what can happen? Well, think about the relationship of the gut. We're not having our filter and we have a white blood cell count concern. So therefore, what can we end up getting? We can get an infection in our abdomen, in that peritoneal space. So it's an acute infection of the fluid in the abdomen and can be seen with liver disease due to that ascites. So what are you going to see? You will see a patient who has a distended abdomen. Their pain, no matter what they do, their pain is getting more severe, more severe, more severe. That patient doesn't even want to turn in the bed, doesn't even want to move whatsoever. Their abdomen is very tight. When you feel that abdomen, it is very rigid. They have a rigid board-like abdomen. That is characteristic of peritonitis. Rigid board-like abdomen is characteristic of peritonitis. The patient will develop fever and chills because it's an infection. They will have that intense abdominal pain, the abdominal tenderness whenever you're palpating, and their ascites will get worse. And it is a medical emergency. You need to contact your healthcare provider. That patient is going to go to have, that patient is going to go to surgery. They do different things in surgery. Generally, they will actually drain the abdomen. They'll clean out, do a washout of the abdomen, and they usually can actually put antibiotic directly into the abdomen as well to help to clean out, because peritonitis is one of those things that you can get septic from real quick. Esophageal varices. Esophageal varices is on page 890 in your textbook. Page 890 in your textbook talks about esophageal varices. It talks about the collateral blood vessels, and it is due to portal hypertension. The thin-walled vessels are very inelastic. They are very fragile, making them prone to rupture as the portal pressure increases. Rupture of these esophageal varices can cause massive hemorrhage. Somebody can bleed out and die. It causes massive hemorrhage. Further exacerbated by thrombocytopenia and impaired production of those clotting factors in the liver, this patient can bleed out and die very quickly on you. So, what are esophageal varices? They're dilated vessels that occur at the lower end of the esophagus. Symptoms, generally, they're asymptomatic initially, but ulceration of the varices can lead to hemoptysis. So they can have the bright red blood, or they can have the coffee ground emesis. Melena, so we can see, because it's the whole entire GI, we are looking at the varices. It's also our patient can have melena, they can have tachycardia, hypotension, and they can have a further decrease in their hemoglobin hematocrit. Diagnostic, so how do they know if somebody has esophageal varices? Well, if somebody has portal hypertension, they're automatically at risk for esophageal varices. So how do they determine if they have them? Because of symptoms, of course. If somebody's coughing up blood, or if somebody has, has blood in it, has the coffee ground emesis, those can be the different things. Or if they have the melena, that can also be a sign that they have some of these esophageal varices, because if they have hemorrhoids and they have the rectal ones, then most likely they're going to have the ones that are in the esophagus as well. So diagnostic is endoscopy, so they'll run a scope down and look. They can also do ultrasound, CTs, and angiography. So laboratory testing, they do the aminotransferase, the AST, they do the bilirubin, they do the alkaline phosphatase, the ALP, and they also look at the protein levels. So what is the treatment modalities? Treatment modalities for esophageal varices. This is kind of where it gets a little bit different in your textbook. So this is kind of why I tried to group some things together. On page 892 is actually where it talks about your pharmacological therapy. So on page 892, it talks about the medications that you use for esophageal varices. The medication that you use is vasopressin. It talks about vasopressin is one of the medications that you use. And why do we use our vasopressin? Our vasopressin, it's a pressor. So what's it going to do? It's going to press on the vessels. So if it presses on the vessels, it's going to constrict them. So if a patient is having esophageal varices, they're going to be on a beta blocker, right? Um, and if they start to bleed, then what are they going to do? They're going to give them vasopressin. Vasopressin is going to press on the vessels, is going to constrict those vessels to help to control the bleed. They're also going to give the patient who has bleeding esophageal varices, they're going to give them octreotide. Octreotide works in the gut and it actually helps with the bleeding. It helps with the bleeding, helps to slow down the bleeding. So if somebody has esophageal varices, yes, they're giving them the beta blockers. They're also giving them the octreotide to slow down that bleed. It works in the GI. And they're also giving them vasopressin to press on those vessels. Now, here is something to remember. If you have a patient who has bleeding esophageal varices and they have a history of coronary artery disease, it would be contraindicated to give vasopressin to that person. Why? Why would it be contraindicated to give vasopressin to a patient who had esophageal varices that were bleeding if they had a history of coronary artery disease? The reason why is because it's vasopressin. It's going to press on the vessels. It's also going to press on the vessels of the heart. So what's happening is it's going to decrease the blood flow to the heart as well, and that patient might have a heart attack. So it would be something that I would question my physician about. If I seen a patient who had esophageal varices and they had an order for vasopressin, and they had a history of coronary artery disease. I've seen they had an MI in the past, a myocardial infarction, or they had acute coronary syndrome. I would be very concerned. I would contact the physician using the SBAR technique, and I would question that order. Another treatment that they can use for those active bleeding varices is the balloon tamponade. The balloon tamponade I kind of explained earlier, but there's a picture of it and it shows how it is. It is the long skinny balloon and it has a whole bunch of different ends on it. And one of those is actually hooked up to a sphygmomanometer and they actually pump that up to a certain pressure. The doctor's the one who decides that pressure. And with that patient, that goes into the esophagus and it presses up against it, it inflates and then it presses up against those varices that are in the esophagus and it stops that bleed. You have to be very, 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 very cautious with this patient, very, very cautious with this patient because we can put pressure on that esophagus, but what other structure is next to that esophagus? The airway. The airway is next to it. So if we put too much pressure, it can cause problems with the patient breathing. Me personally, I've only seen one patient who had a balloon, who had esophageal varices with a balloon tamponade. And this one, they did not want to lose that because it was in the esophagus. They didn't want it to go anywhere. So there was a string that was tied around it. We had to keep scissors at the bedside. And the reason why we kept scissors at the bedside is because if that patient started having any kind of respiratory distress or respiratory was compromised, we were to grab a hold of that balloon and cut that string and pull that out of there because the airway breathing circulation, we had to make sure that that patient had an airway. So that was one of the things that we had done. And that was a while ago. So I remember that patient was on a ventilator as well, and I was thinking, well, why do we still need scissors if there's on a ventilator? Well, remember, even if you have a ventilator going, you're pressing against the esophagus, and if there's too much pressure against that esophagus and it starts impeding on the airways, you can have them on the ventilator and be given whatever 100%, but they're not going to get that if that airway is closed off. So that makes sense now. Another treatment that they would do is the transjugular intrahepatic portosystematic shunt that we talked about. Transjugular, remember they go in where? They go in through the jugular and the neck. They go down to the portal vessel and the liver. And what do? They put a shunt in to help to decrease that portal pressure. They shunt that fluid. So nursing management for esophageal varices, of course, is nutritional status. Our patient will be on complete bed rest if the esophagus is bleeding, and the patient, of course, is NPO, and that patient will be getting TPN. Gastric suction might be ordered for that patient to keep that stomach as empty as possible to prevent any straining or any vomiting. We'll make sure we're doing oral care in a quiet environment and reassuring our patient. So treatment for portal hypertension, we talked about that TIPS procedure. I just wanted to give you a picture of it. So the TIPS procedures, the transjugular route, the shunt between the portal circulation hepatic vein decreases that sodium retention. It also helps to prevent recurring fluid accumulation in ascites, and it helps to decrease the chance of those varices, esophageal, GI, and rectal. So now let's talk about hepatic encephalopathy. Hepatic encephalopathy, there's a good picture for you. So take some time and look at that picture. We'll see that there's changes in LOC, stupor. Our patient has impaired thinking and judgment. Our patient has asterixis. 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 Asterixis is also known as a liver flap. That is a test that you can do at the bedside to test your patient to see how, if their ammonia level is continuing to build. So I'm at the bedside, I'm taking care of a patient. My patient seems to be more confused than what they were earlier. So what can I do? I can do this little test at the bedside. I can test for asterixis, and I can have the patient hold their hands out, and what I will see is they'll have a change in that posture. We'll see that liver flap. So what will happen is that hand will actually start to flap down, or we'll actually see tremors in the hands as well. Those are things that we can see at the bedside that indicate that that ammonia level is getting higher, that that hepatic encephalopathy is getting worse. The other one I want you to write on here is apraxia. APRAXIA, apraxia, APRAXIA. This is difficulty writing. So this is another test that you can do at the bedside to check to see if that ammonia level is rising and if that hepatic encephalopathy is getting worse. What you do for apraxia is you have the patient write their name, and then over time you have them write their name again, or you ask them to draw a star. And what you'll notice is the patient, they'll write their name and they know their name and they want to write their name, but their handwriting, they can't write their name. Or over time, what I will see in an hour or 2 hours is that the patient's handwriting is getting worse. They can't form the letters of their name, or I ask them to draw a star, and when they draw a star, it's not a complete star. They just have lines kind of everywhere. They know what the star is, or they know how to write their name, but because of the toxins build up in their brain, they are unable to actually draw it out. And that is called apraxia, APRAXIA. Think about the P. P for paragraph. They're trying to write something. They're writing their name, or they're writing about a star, trying to draw a star. Asterixis is the other one that you can do at bedside. Asterixis, ASTERIXIS. It has a T in it. It has the letter T in it. So think about them holding out their hand and trying to wave a taxi, and their hand flops down, or there's tremors. Those are very characteristics. If I think my patient has hepatic encephalopathy, I can do these two tests at the bedside. I go to the chart, I try to see what the ammonia level is. There hasn't been an ammonia level drawn in 4 days. I can do an easy test at the bedside to see if that ammonia level is rising. I can do an easy test at the bedside, my 2A tests. Hepatic encephalopathy is the inability to detoxify toxic by production of metabolism. It's a complication of portal hypertension. Once again, there is an increase in ammonia levels. The patient has excessive diuresis, dehydration, infections, surgery, fever, and with their medications, this patient is just, they have a lot of stuff that's going on with them. And so a lot of different things happen for our patient, and we do not want our patient to have any of these kind of side effects on here of um, these mental changes or alterations in mood and sleep patterns. And so we are going to be assessing our patient, and we are going to be making sure that we are giving our lactulose to this patient. Give your lactulose to that patient. I'm just noticing here on our slide, it says excessive diuresis. I think that was an error on my part. I do apologize. Please cross off the excessive diuresis, dehydration, infection, surgery, fever, and medications on this slide. I do apologize. Just strike through that. But I do want you to write down beside that asterexis, I want you to write down that's the hand motion to test for hepatic encephalopathy at the bedside. And then I want you to write down also apraxia, A-P-R-A-X-I-A, A-P-R-A-X-I-A. That is the trying to write their name. Think of the P, underline that P. They're trying to write their name or draw a star and can't do it. This patient who has hepatic encephalopathy, what is the treatment? The treatment is lactulose. Lactulose is the medication that we give. As we look on page 892, that's where it'll explain to you about the pharmacological therapy, the medication specifically, lactulose that we already talked about. As we are on 34 slides in, yes, this is long. There's a lot to go on with liver encephalopathy treatment and management. What are you going to do, nurse? You are going to assess this patient's neurological status. You are going to assess for awake, alert, oriented to person, place, and time. You're going to assess their Glasgow Coma Scale. You are going to monitor their mental status, make sure they're making sense. Are they repeating themselves? You're going to assess this patient's INO, their daily weights, their vital signs. This patient is a liver patient. You're going to observe for signs and symptoms of infection. This is a liver patient. We're going to monitor our ammonia levels daily. With this patient, we need to be very, very cautious and very, very conscientious of their protein intake. Their protein intake only needs to be 1.2 to 1.5 kilograms per kilogram per day. Very key for hepatic encephalopathy. We need to monitor their protein intake. 1.2 to 1.5 grams per kilogram per day. They cannot metabolize protein. If we give them more, they're not going to be able to break down the protein. The ammonia is going to build up. The encephalopathy would be worse. We do want, for this patient, we need to make sure that they do have nutrition. So if they have encephalopathy, depending on what their ammonia level is, this patient may or may not be able to eat by themselves. So this patient might be okay 1 minute, and then we've given them the lactulose, and after they've had several doses of their lactulose over a 24, 48-hour period, they are more awake, more alert, they're able to talk to us, they're able to eat, and they're better. But we have some patients who their ammonia level is not coming down and they're getting worse and worse, or they have other things that are going on with them, and these patients require enteral feedings or parental nutrition. With our patient, they are a liver patient, so we're going to monitor their electrolyte status. As we continue, Hepatorenal syndrome. Hepatorenal syndrome. We are back again on page 890. Page 890, hepatorenal syndrome. So with this, its complication of advanced cirrhosis occurs as blood volume increases in the dilated splenic circulation, causing reduced arterial blood volume. This activates the RAS system, and then we have vasopressin, and that responds, and renal vasoconstriction helps happen, sodium retention, edema, and reduced absent urinary output. It can develop rapidly following one specific triggering event, such as an infection, or it may progress over time. But our patients are at risk for this, so be alert for it. So I think we've talked about all the different things that are in your chapter for your content regarding your liver disease. The only thing we have to go over is a hepatitis A, B, and C. So hepatitis A, B, and C content. So this is located in your part of your immunity content. It talks about, but I have put in some good resources for you to look at in your content. We'll take a quick run through and let's talk about hepatitis A. Hepatitis A is curable. How do we get hepatitis A? Hepatitis A is transmitted from fecal to oral, so wash your hands. Wash your hands. Hepatitis B. Hepatitis B and hepatitis C, how are they transmitted? They're through blood products, blood exposure, and also through sexual fluids. So that's why we want to make sure that we're conscientious and we don't get needle sticks. We're making sure whenever we're starting an IV, we're wearing gloves. We want to educate about transmission. All of these, hepatitis A, B, and C, we need to educate about transmission. We need to know how they're transmitted so we can teach our patients. So if we look at this slide, hepatitis A, they usually have an acute illness. It usually lasts 3 weeks, but can be persistent up to 6 months. So what are they going to have? They are going to have symptoms of fatigue, abdominal pain, nausea, jaundice, fever, diarrhea. So it can mimic the flu. And transmission is household contact, usually with food or water, or contaminated by feces. So fecal oral. If somebody has hepatitis A in the home, they do not need to be sharing eating utensils or drinking from the same cups. Um, we need to make sure we're teaching our patients whenever they go to the farmer's market and they're getting their fresh fruits and vegetables. We're making sure to tell them whenever they come home, make sure they wash them. Make sure they wash the fruits and vegetables that they get at the farmer's market. Make sure you're washing the fruits and vegetables that you're getting from the grocery stores. Make sure you're washing your hands before you prepare food. Make sure you're washing your hands after using the bathroom. Hepatitis A, people can get it from if somebody has hepatitis A, goes to the bathroom and has a bowel movement and then goes and prepares your food at a restaurant without washing their hands, they can contaminate your food and now you have hepatitis A. Hepatitis A, there is a vaccine for it. It is curable. Um, let's talk about hepatitis B. Hepatitis B, most adults recover fully, but virus is the major cause. It causes scarring and that's cirrhosis, and it can also cause liver cancer. So B is more severe. Hepatitis B cannot be cured. Symptoms include fatigue, abdominal pain, nausea, dark urine, joint pain. We also see joint pain with this and jaundice, and about 30% actually don't have any symptoms at all. So it goes undetected for a long time. And then the damage is already done, and the liver is, they actually have cirrhosis. There's so much scarring on the liver by the time they actually are diagnosed with it. Mainly, transmission is through sexual contact, although sharing drug needles or other exposure to infected blood. So make sure you're wearing gloves whenever you're doing blood draws on your patients, and make sure you're wearing gloves whenever you are starting IVs. Any blood that you come into contact, you need to make sure that it does not touch your skin, and you need to wear gloves. Hepatitis C slowly, hepatitis B, there is a vaccination for it. There is a vaccination for hepatitis B. Hepatitis C, Hepatitis C is slowly progressing disease. Most cases occur in the young adults. Symptoms are mild fatigue, abdominal pain, nausea, jaundice. 80% of them have no symptoms. So this is another one that can go on for a long time and patients don't know that they have it. So how is transmission? Shared drug needles, sexual contact, blood transfusions before 1992. So it's sexual contact and blood, and so we need to be educating our patients. There is no vaccine for hepatitis C. They are doing some research for treatments for it. But diagnostic of hepatitis, whether it be A, B, and C, they look for the presence of a specific antibody antigen in the serum. And treatment for all types is rest, activity as tolerated, nutrition, and hydration. So it's hepatitis. Hepatitis is a liver disease. So whether we call it hepatitis, or whether we call it cirrhosis, or we call it fatty liver disease, the liver's not working. The liver's not working, so we are going to see all the same signs and symptoms no matter what the cause of the liver disease is. We are going to see the liver is not working. And so when we're thinking about the causes, that's what's going to be differential. Differential is going to be the cause, whether it was a virus like hepatitis A, B, or C, or whether the cause was alcohol, or whether the cause was the medications that I took for my other longstanding health condition that damaged my liver so bad that now I have liver disease and I have liver failure, right? So liver disease is liver disease. It's going to present all the same. It's what's the cause, okay? Um, Hepatitis A, B, and C, make sure you read that information that I have put online for you within this content. Um, you will be seeing it on your board's exam. Cirrhosis. Cirrhosis just means we're at end stage. We're at end stage. There is so much damage, so much sclerosis, so much fibrosis. It's degeneration of the liver from general cellular damage. The liver becomes unable to carry out the following functions, which is metabolism, coagulation, regulation of its electrolytes, and of the body, and impaired ability to metabolize the hormones. Most common is alcoholic cirrhosis or post-necrotic cirrhosis or biliary cirrhosis. Cirrhosis is cirrhosis. Liver's not working. It's very scarred. So what are we going to see? Liver enlargement. Well, liver enlargement, what will we see it on? We'll see it on the ultrasound. We can see it on a CT, an MRI, but also we can feel it. We can feel it when a patient has cirrhosis, when a patient has liver disease, and they have an enlarged liver, you can palpate the right upper quadrant. And when you palpate the right upper quadrant, you'll feel that it is enlarged. So a patient who has liver disease, we palpate on their abdomen in the right upper quadrant. If we can feel that patient's liver, they have damage to it. When the patient has cirrhosis, we have that liver enlargement, but as time goes by, that liver gets very fibrotic and it kind of just shrivels a little bit. So we may not be able to feel it. This patient does have portal obstructions and ascites. We have infections, peritonitis, gastroesophageal varices, edema, vitamin deficiency, mental deterioration. It's all those signs of the worst case scenario because this patient has had the portal hypertension for a little while now. So nursing interventions, what are we going to do? Promote rest, improve nutritional status, provide skin care, reduce risk of injury, monitor and manage complications, bleeding, hemorrhage, hepatic encephalopathy, fluid volume problems. we are going to monitor and treat all of this. We will be working in the classroom, talking about what we will do in general for a patient who has a liver problem. We will be talking about what labs we're going to look at. We will be doing some activities that are going to be reinforcing our learning of this content. So be prepared to actively engage in class regarding a patient who has a liver disease. Then we're going to take it further because the patient has now developed portal hypertension. Now that the patient has developed portal hypertension, what complications are we going to see now? And be expecting to run through the scenario of this patient has now developed ascites. So, what medications are they going to prescribe to this patient? What are some nursing interventions that we're going to do for this patient? What are some teachings that we need to do now? The doctor has, or what is some complications that this patient has had, like maybe the patient's having difficulty breathing, or maybe the patient has now developed peritonitis, and or the patient is now going to have a paracentesis. So be able to walk through all these problems. The patient has now developed esophageal varices. How would you know that they have developed esophageal varices? What would you see? And what would you do? What would you do for this patient? We want to think about the patient with the liver disease, and we want to maintain them as long as we can, and we want to prevent complications. When complications occur, we need to be able to recognize them and respond quickly to decrease the amount of damage that it does for our patients. We need to be responding to what we're seeing. What are our cues? And then because of we have these cues, what are we hypothesizing? What are we thinking is going on with this patient? And then what are our interventions going to be? What are our interventions for this patient? When we go to the chart, what do we think that the physician is going to have ordered for the patient? What do we expect the labs to look like? And then we're going to implement these interventions, and we're going to use collaboration, and who do we need to get on our team and why, and how are they going to help us? And then we are going to come back and we're going to evaluate and figure out how that worked and what do we need to modify in our plan of care. And that is the nursing process. So we will study in the nursing process, and we will put the nursing process into action whenever we meet for class.